Today, we have Dr. Scott Sperling joining us for conversations with experts. He's a board certified in clinical neuropsychology and a staff clinical neuropsychologist in the Center for Neurological Restoration at the Cleveland Clinic. He's a clinician, a researcher with expertise in Parkinson's disease and functional neurosurgery for movement disorders. He earned his doctorate degree at the Wright Institute and completed his pre-doctoral internship at the Jesse Brown VA. He then completed his postdoctoral training in clinical neuropsychology in the Department of Neurology at the University of Virginia, where he worked as an associate professor before moving to Cleveland in 2020. He's committed to professional service, has served as chair of the APA Division 40, Society for Clinical Neuropsychology, Education Advisory Committee, co-chair of the Strategic Planning Committee, and director of SEN Student Leadership Development Program. He was also one of the representatives for SEN to the Minnesota 2020 Update Conference. He also co-founded Know Neuropsychology and has served as a chair of APA's Committee on Early Career Neuropsychologists. So thank you, Dr. Sperling, for being with us today, and I'll hand it over to you.
All right, thank you. Thank you for having me here. Can I share my slides? Does that work? Let's see here. See, we can't work with technology for our technology talk. All right. Are we good? All right. So thank you all for being here. I know, Zoom land, I guess we're kind of used to it now, but, still all day in front of computers, and some of you, I'm sure, are at lunchtime now. So thanks for working on me here. I'm going to talk to you a little bit today about teleneuropsychology, and my hope is that I can do this through a bit of a different lens, or perhaps a sort of a different, setting this up in a bit of a different context than maybe most of our discussions have had on this front up to this point. So just a couple quick disclosures, nothing major, but I just also sort of want to kind of let you know where I'm coming from here. So at the end of the talk, I'll have a slide that I'll show that gets at a study that I'm have up and running here at the Cleveland Clinic around teleneuropsychology and Parkinson's. But I think more to the point, the majority of my work and the paper that was just put out is really a byproduct of what I do with APA's healthcare finance team. So I work with Stephen Gillespie and Neil Pliskin now on the CPT and RUC side of the process. So Neil is still primary for the CPT, and I'm primary for the RUC. And for those that you don't know, it's kind of a two-stage process where, if we want billing codes to be, adopted by Medicare and then hopefully downstream by private payers, the first process is, getting them approved by CPT, and the second process is that it moves over to the RUC where they're actually set up for the valuation. So I'm heavily involved in that, and that's really where this comes from for me. So I think the title of the paper that we have is really about practice the policy to science to practice the policy, and really it should be the public health as well. And I want to start off with the obvious as well here. So hopefully these are not issues or topics that are necessarily up for debate. At least they aren't in my mind. But again, I think context is important, right? So I would imagine that for the 20 of us or so here on the talk, we can agree that clinical neuropsychology services or evaluations are medically necessary, right? What we do is important. It can't be substituted by other people, other specialties, other technology. Computers aren't doing what we're doing quite yet, right? So whether you're talking about assessments in geriatric populations, diagnosing differentiating neurodegenerative diseases, if you're talking about pediatrics and school-based evaluations and accommodations, or anything in between. Again, what we do is important. So the point of this for me, as we'll get into, is if what we do is important, if we can all agree that it's medically necessary that we provide neuropsychological services, then we need to ask the questions about, are we doing that in a way that makes the most sense, reaches the most people, and reaches people in a more equitable fashion. That's why my other sort of point here of things that are hard to argue are around health disparities, right? We know that there are a vast degree of health disparities that exist across the world, but certainly within our country for a whole litany of sort of socio-historical reasons, and neuropsychology is not immune to this, right? So if we just look at this, the SWEET data from the last 2 years ago now, just in terms of just access for our services alone, 7% of us practice in rural environments, and the last time I checked, the United States is not a small region. There are a lot of rural environments, and we don't exist there. Over half of us practice in 9 states. We know that over the years, there's been a decline in the percentage of folks that are practicing as lifespan neuropsychologists. We know there's not a lot of neuropsychologists, and there's not a lot of pediatric neuropsychologists. And of the pediatric neuropsychologists that are there, the vast majority of those practice primarily at academic medical centers, right? So you take the fact that, we simply don't exist in large swaths of the country. There's what I call neuropsychology deserts. You compound that by the fact that there's massive wait times for clinical neuropsychology services, and we have problems in healthcare access, right? So again, these are facts, and it is our it is up to us as a specialty to acknowledge them, and B, decide if we actually want to do something other than just acknowledge them. Okay. On the list of things that are also facts and obvious, right? Things that I would hope that we would care about are cost, right? We live in America, and it's a for-profit healthcare system. We live in a capitalistic society where healthcare comes at a cost. So you have direct cost, but you also have indirect cost. Again, if you think about the burden financially and otherwise that it takes for people to access all healthcare services, including, if not even oftentimes more so, neuropsychological services, given the fact that we don't exist in a lot of places and our evaluations take a long period of time. You have things like transportation costs, the losses of income, whether it's, I'm taking an unpaid day of work, or I'm taking if you're still using vacation or sick leave, that still counts as a cost, right? What do we do when we have folks come to our clinic? Do we tell them to bring, their parent if they're a kid? Yep. Do we tell them to bring their family, their spouse, their partner, if they're an adult or older adult? Yep. So now we can double down on the indirect costs, because these can often be assumed by, more than one individual, right? These are real. And then we know that we often deal with a lot of frail patients, right? So frail, or just issues in terms of safety and mobility. So whether it's movement disorders, it's MS, you have pediatric patients where there's maybe not just physical or neurological, but there's psychiatric comorbidities. There's things like irritability or agitation that occurs, or long car rides, let alone what it takes to park in a garage and walk the 40 minutes it takes to get to my clinic, if you can even find it in this hospital, right? I mean, these things are real. And if we are thinking about what it means to optimize patient care, which is something that I would argue that we should be doing as a specialty, right? How do we provide optimal, patient-driven, sort of person-centered services? Does that mean that we need to do the same darn thing for everybody? And does that mean that we need to bring everybody, particularly with these risk factors, into our clinic for these standardized evaluations? All right, so those are what I would suggest, again, as just those are the facts, right? And then obviously when we're talking about telehealth, we're talking about it over the last, I mean, we've talked about it before the last 3 years, but we're really talking about it the last 3 years because of COVID, right? So we're somehow 3 years plus now with COVID. The public health emergency, or PHE, started early 2020. I'm kind of sort of parsing things down here. Most hopefully we have some time for conversation. And actually, I should apologize to say, if anybody has a thought or question, just jump in. I'm pretty easy here. So, um, but the this nuts to bolts allowed for us to be able to provide healthcare services, including the neuropsychological testing services to patients in their home. And this was something that wasn't necessarily available for most people before. I don't have a lot of slides and kind of the history of sort of where telehealth came from in the States, really from a CMS standpoint, including Teleneuropsych. But there are sort of multiple sort of landmark policy decisions and laws that were sort of put forth that sort of expanded things over time. Some that have to do with the location of services, some with in terms of reimbursement, and how that would play out between the providers either providing the services in different locations. But nonetheless, we were able to do this for 3 years. So that's good, right? We also know that there's guidelines, right? So we can do this, and then many of us are saying, well, how do we do it? Where's the help? And if you go back pre-pandemic to 2013, big APA set up guidelines for the practice of telepsychology. And yes, neuropsychology is psychology, and yes, the specialty of neuropsychology is part of the American Psychological Association. There are very few things that from a jurisdictional standpoint anyway, that are like neuropsychology or specialty specific. So at least there were some broad basis for what teleneuropsychological practice would look like, over a decade ago. And then obviously the IOPC set up their guidelines in pretty rapid response to the pandemic. And we know, so there's a handful of survey studies that were done really looking at data or information primarily for the kind of the first year to year and a half of the pandemic. Early on, about some of the early data was showing that somewhere around 3 to like a quarter, 25% of folks surveyed were performing some type of neuropsychological testing in the pandemic. Some data thereafter that shows that there was sort of an uptick in that. But I think, certainly, mid-pandemic on up till now, we really don't know how many folks were using telehealth platforms to conduct neuropsychological assessments, and really specifically what it means when we say, I'm doing neuropsychology. This is a problem that I have with a lot of the published data, and really just in the way that we talk about these services, in sort of lay fashion, because we know that, neuropsychology is not one thing, right? So if we say that we have a teleneuropsych practice, are you talking about conducting a clinical interview, providing feedback? Are you talking about brief cognitive testing? Is that brief testing, the tics? Is it, is it a small battery of tests? Or are you really talking about the whole package, right? They're fundamentally different things. And that'll play out from a coding and billing standpoint as we talk further, because there is differences between being able to provide allowances either on a temporary or permanent basis for some aspects of so I should say some aspects of neuropsychology practice, so namely, say, the clinical interview or feedback, and not others like the actual testing itself. And that actually holds true from a psychological testing perspective as well, not just neuropsych. So, what are the barriers? These things are probably not shockers to you. We've talked about them amongst the friends and colleagues. They've been on listservs, and there's published data on this as well, really thinking about what are the actual barriers to, implementation. What were people fearful of, at the start of the pandemic, and then, as the years moved on, what caused the specialty, what caused a sort of hesitation or resistance to adopt practice changes and utilize the telehealth platforms to a kind of a fuller capability. So, really, on the top of the chain here, uncertainty about the feasibility and the validity were widely expressed for those who who had concerns about validity or didn't. There was still concerns about personal practice and sort of the lack of familiarity or comfortability that folks had with their own training in conducting these particular services, and a lack of specific guidelines as to how to do it. So you have these sort of IOPC guidelines that were kind of broad, but in terms of the nuts and bolts about, what types of testing to do with which patients and how to do that, because this was newer, given obviously the rapid onset of COVID, there wasn't, a guidebook for people to kind of turn to. Then there's obviously, other issues that sort of popped up around, concerns around test security and, at the time reimbursement, although most of that got ironed out actually fairly quickly, even from a private payer standpoint, at least in a general sense. So where does that leave us now, right? So the public health emergency ended in the spring. We are somehow in mid-October, which is also mind-blowing to me. And with the expiring public health emergency, so too are the multiple waivers that CMS provided for telehealth, not just with neuropsychology, psychology, but across medicine, across healthcare. All right, so the vast majority of the services that were put on this sort of temporary list of being these waivers that you say you can do these services via telehealth, they're essentially, the waivers are set to expire at the end of this year. Now CMS has, CMS and, pretty much everybody, to their credit, has recognized that, just pulling out the rug from, underneath medicine, and, patients, in terms of removing the telehealth services that we've been providing for over 3 years is just not, it's just not a good idea. All right. CMS understands the benefits of telehealth broadly, both from, an access side of things, and to, just broadly healthcare, and the patients like it. Satisfaction is high, and it's pretty high across providers as well, across specialties. But there's still not going to be sort of this situation where everything just stays the same. So the ongoing process over the last year or so, and through now, is to decide, what are we going to do, both short term and long term. Right. And so these are part of conversations that APA and others are a part of. And nuts to bolts, there are 2 telehealth lists. Okay, so CPT, which this is our the billing team, right? This is, I kind of cut out some of the slides, but this is basically the House of Medicine, right? So APA has the one representative to the sort of the CPT process, as do all the other specialties. But this is, it's a American Medical Association group, right? To kind of keep it simple. So there's a CPT process, and then there's the CMS, there's the Medicare process, and these are closely intertwined, as you would imagine, but they're 2 separate entities. So going back to actually what I was saying earlier in the introduction, kind of really the way things work from a billing standpoint, and the super simplistic way, is that codes get either approved or revised by CPT. It then goes to the RUC for valuation. This is where your RVUs and actual dollars and cents come into. We will, there have been, I've seen this literally 2.5 hours of discussion, debate, and argument over how much like a 1 tablespoon of like sunscreen costs. Like that's the nitty gritty which things get at. And then the valuation then goes to CMS. It's essentially just a recommendation, and CMS decides whether they want to accept the RUC's recommendation for the valuation, throw it out, change it, or they can kind of do whatever they want to do. So that's kind of the process. But both the CPT and the CMS have these telehealth lists, and if your codes are not on at least one of the lists, you're pretty much dead in the water. All right, there's no way that either from certainly from the public, but even from the private payer side, that you're going to have your services reimbursed. And if services are not reimbursed, people don't provide them. Right, and That's just sort of an obvious thing, but should be underscored. That's why we're talking about this relationship here between healthcare finance policy and practice and really population health. So we're at a point of trying to say, what do you need to do to get on these lists? And over the last year, there's been work to really establish what this criteria is, because it really hasn't been outlined before, because this is all fairly new. And it's a little bit different for each one, but in broad strokes, what you need to show is that there's some substantial evidence from well-conducted randomized controlled trials that show that the services provided via telehealth, they work, they're effective, they have an impact on healthcare outcomes, whether that's diagnoses or treatment outcomes, and then we're not fully there, but some growing acceptability of trying to understand, again, really from more of an objective and evidence-based way, that the provision of the telehealth services has an impact on healthcare access or population health. So that's important, but really the primary driver here is going to be RCTs around efficacy. And that's actually kind of why, really where I got into this. That's the only reason I'm actually talking to you today. I don't like to make a lot of assumptions because I think they tend to be fairly dangerous and usually faulty. But certainly mid-pandemic I was still working. I was in clinic. I was still doing my Parkinson's research, and was actually trying really hard to sort of let's create certain lanes, and other people will do other things, and you don't need to be the person that does all the things. They can preach to the trainees, right? So I wasn't I was interested in teleneuropsychology from a public health standpoint, given that we were in COVID, but I wasn't inclined to do any particular research in the area. And then, being now for the last handful of years involved directly in this sort of the CPT and CMS process, becoming increasingly aware that, as I'll show you, neuropsychology doesn't actually have the science, doesn't have the evidence that we would want in order to be able to substantiate claims around efficacy, and then becoming sort of fearful / angry about that, and fearful that what would happen is that after the end of this year, or maybe at the end of 2024, if we can get on like a temporary waiver for the following year, that our ability to provide these services would disappear. Kind of what I call if there is a silver lining to COVID, right? From a practice standpoint, that's kind of window we had to do the science, and this impetus that was put upon us from a specialty to conduct really good studies in teleneuropsychology, that frankly wasn't being done. If you look at the published studies since, say, March 2020, there have been a little over 100 studies around teleneuropsychology. But there's actually, contrary to at least what I would expect, there has been a decline. There's a decline in the number of studies from the year 1 of the pandemic to year 2, and then stagnation from year 2 to year 3. So we're not seeing what I would thought to be sort of a steady uptick in the science in this area. We're seeing the opposite. And then if you look at the publications in and of themselves, the majority of the publications are not scientific studies, right? So we have a ton of publications, I should say, out there that are sort of some combinations of reviews, a lot of descriptive analysis of practice models or hypothetical practice models. Qualtrics is everybody's favorite thing in the world. We have Qualtrics. It's easy, so we'll survey everybody to death about everything, and then write it up. Lots of white papers and editorials. So I get this. This makes sense. Early COVID. It takes time to do science. So there was this sort of influx of people trying to support each other and sort of figure out where the specialty is going. But the issue is that the issue isn't that wasn't understandable or even helpful at that time. It's that that type of work was really what predominated over time, or everything just dropped off, to a kind of a large degree. So again, you have a lot of these non-experimental studies, and then you have or papers, and then you have another kind of group, a bucket of studies that look at in a sort of a non-randomized fashion, uh, uh, sort of teleneuropsychology, right? So within kind of big buckets, I think it's important to think about what are we examining through the research, and I don't think the specialty has actually done a great job in being very objective in terms of how we analyze the teleneuropsychology research. Yeah, I think we could do probably a little bit better job being actually accurate in the way that we're describing our work, as we're publishing, and then really how we're talking about it. I mean, and these are even simple things like if we're talking about is your paper around feasibility and acceptability? Is it around reliability or validity? These are obviously different things, but if you actually scrutinize the research, it's not as neat as you would hope that it would be. So I'm not going to break down, because I do want to leave time for discussion. So I'm not going to break down, all the studies that have kind of been out there. But in kind of bigger buckets here, there is a good number of studies of, not randomized work, but scientific studies looking at teleneuropsychological testing relative to, in clinic, in-person testing. Some of these were done in clinical populations, some in healthy. In the clinical populations, they include like a few with pediatric samples. There's neuro-onc, MS, and HIV. So you do have kind of a nice breadth. A lot of these looked at either two sets of kind of retrospective data, or they compared some compared prospective, research from a teleneuropsychology arm, and then did a kind of a matched control sample, from the EMRs. So again, not necessarily a fully prospective, RCT, but important work and really foundational work. And if you look, really across these, couple dozen studies that are actually starting to examine the reliability of teleneuropsych testing, and most of this is really looking at in a different correlation analysis. Is a score from one setting similar to a score on another setting, and by and large, they are. So again, really important and good foundational work from a retrospective standpoint. Okay. In terms of the randomized control work, and I should actually be a little careful too. We say randomized control. They're not technically randomized control trials, because we're not performing an intervention. We're really talking here about more of randomized methodology. We're randomizing, patients into particular, in home or even just, teleneuropsych versus, traditional testing. But of these, I counted about 20 RCTs looking at the reliability and the validity, and really that should just say the reliability, because at least the last I checked, maybe 1.5, without, we'll call it 1.5, and I'll leave it there. Looked at validity. So again, really what we have are studies that look at test scores, a score from one condition to a score to another condition, and trying to say, are they equivalent? Okay. Of these, most, or at least half, I should say, were done, in home. About half in home, half were done in like another hospital setting or clinic. And the majority of these were studies that looked at, maybe one or two, or just kind of a few different tests. So important, but still, again, fundamentally different. So when we talk about teleneuropsychological evaluations, are we talking about a brief cognitive assessment, or are we talking about, the whole thing? Both are fine, but we need to be more specific and accurate in the way that we talk about our work. Again, just sort of in the big picture, we can go back to, Monroe, and others good work, well before the pandemic. looking at the feasibility and the reliability, good work done, saying that this makes sense and it's reliable if you go, from one video camera in a clinician's office to another video camera in a controlled setting and, in a hospital, right? And that was done in healthy adults and folks with MCI and Alzheimer's disease. A lot of good, early work here. And, Morell will tell you himself that, when he was doing this, a decade ago, his assumption was that this was sort of going to be foundational, and that others would sort of pick this up and really expand upon it. And we really have more studies looking at teleneuropsych, both from a reliability and a validity standpoint, in different clinical populations and at home, and it just simply didn't happen. Okay. In terms of some of the in-home work, which is really where my interest lies, a few studies look at this work in healthy adults. So you can kind of see here, I don't either kind of read them all off for you, but we have, there's a handful of tests, some from some brief screening tests to others looking at, from a counterbalance design standpoint, the reliability of teleneuropsych testing in healthy individuals. And at a clinical population, again, being at home, last my count as we have 5, which is better than 0. It's better than 4, but it's not an abundance of evidence, particularly when you kind of break down some of the studies. So just as kind of high level highlights here, one of these, we see that in a sample of patients, adults with multiple sclerosis, the single-digit modalities and the CVLT were shown to be reliable. We've got a study looking in adults who've had a stroke, and there's evidence that extensive language testing, and here a really nice study by Chapman looking at more extensive neuropsychological testing post-stroke that show reliability between conditions. In pediatric patients with sleep disorders, the WASI, 2 subtests from the WASI were shown to be reliable. And then Dr. Harder's really nice study here, again, in pediatrics, ages 6 to 20, showing that in those with demyelination disorders, it's always funny. I always go to say comprehensive neuropsychological testing because it's a really nice full battery that looks like a full day of testing for me as a geriatric neurodegenerative person. And then she has to remind me that that's actually more of a brief battery for peds. But nonetheless, it's still a pretty darn good job. And there's high satisfaction from the folks that, were part of the study, and again, good reliability. So we have some good foundational evidence of the reliability of teleneuropsych, but we don't have a lot of studies. Wadsworth, back in the day, showing one around sort of the validity of testing, but nothing else really other than that. We have few randomized control studies. Most aren't done, in home. And I think that's where our next steps are, right? So if we want to be developing, and this is where I suggest that, we should be doing and thinking about as a specialty, if we want to be developing the science to substantiate a practice model that's going to allow us to more directly, more quickly and effectively address the healthcare inequities, around healthcare access, then for me, having somebody do teleneuropsychological testing in the office down the hall for me is not going to cut it, right? That doesn't mean that there's never a situation where that's important or relevant or helpful, but it's a different goal, right? If my goal is really, it's thinking about the healthcare issues around healthcare access and inequities. So to do that means that we have to be able to figure out if we can do this for, real people with real problems in their home, right? Which means that we, aren't trying to have an RA or a nurse there with them, because that's not going to be, we're not going to be able to do that and scale that up from a practice model. I don't think it's scalable or sustainable from an economic standpoint to be mailing tests and materials to patients, or have them, mail those things back to us. So, again, I'm sort of, how I designed the trial that I'll show you is really about what would be maybe the most, at least in my mind, most practical way of really having a sort of a telehealth clinic without extra hurdles. And then is that model, not just reliable, but valid? And I think we need to be talking about validity. And I think we need to be having more careful and measured conversations about where call kind of where we can set the bar for what we are assessing, and really think critically about what it is that we care most about. For me, it's not that I don't care about reliability, but whether trails or FAS is as a reliability, across, in home to in clinic conditions of 0.88 or 0.9 or 0.92. I don't care. I don't care unless that's actually going to affect the validity. What I care about is my work as a clinician. Can I do a good job, right? Is what I care about every day. Can I use the clinical skills that I have to make sure that I am conducting assessments that lead me to correct diagnoses that appropriately inform clinical care and clinical treatment outcomes for patients and their families, right? If I can do that, then I personally, I'm good to go, right? And I don't care about the 0.9 versus the 0.8. So I think we need to be designing our studies that really allow us to more accurately and intentionally look at validity, and to be thinking beyond even the traditional statistical methods from a reliability standpoint, these correlation analysis, and really be thinking about other more advanced statistical methods of assessing equivalency between conditions. And you do see some of this in some of the other telehealth literature, if both in medicine and even in psychology, and not necessarily from a testing standpoint, but in other aspects of, say, psychotherapy. And so what I'm kind of getting at here is challenging assumptions, right? I do think, kind of going to that bar kind of metaphor, I think a lot of the conversations I've been part of or kind of witnessed to over the last couple of years, I don't think we're on the same playing field. I think there is oftentimes a false sort of equivalency, or how do I say this? I think the notion of what our traditional, in clinic practices, I think there's a sense that it's more pure and impervious to error than it actually is. And I think when we start saying, we need X, Y, and Z to be comfortable in order to deliver teleneuropsychology, it's like we need this thing to be perfect when what we're comparing it to is far from perfect, right? And so just as some examples, just our traditional practice models, in clinic settings, we know that there's variability around both the neuropsychologists and certainly the psychometrists. We've got two new psychometrists here, and I've got some that have worked for 20 years. They're not the same, right? They're not the same, and both make the old sort of good, reliable sort of scores in the broad sense, so I can get valid results from them. But you can't tell me that there's no degree of error variance within their sort of test administration or scoring. And yet that's what we're worried about from a teleneuropsychology standpoint. I've got a helipad outside my office. That damn helicopter comes all the time, and I can't think. I'm pretty sure my patients can't think, right? There's noise in what we do is what I'm saying. There's interruptions. There's also things, like if we look at the other kind of broader healthcare literature, we know that the congruence or lack of congruence between demographic and cultural identities between practitioners and patients has significant outcomes in terms of healthcare. And that's for a 15-minute at most, say, visit with a primary care doctor. And if you're going to tell me that doesn't play into really intensive, cognitive testing over 2 hours, I think I would say that that's probably, not the case here. We have to be just understanding all of these things that come into the room when we're thinking about our data. And we also need to be, understand that when we think about sort of where and how we conduct testing normally, like we often test in situations that are well outside of what the standardized process is, right? And that's always the argument. Well, the tests weren't standardized in this way and they weren't normed this way. Well, tests weren't normed in inpatient hospitals. They weren't normed in state prisons. They weren't named, I've tested in a like in hallways and like a vacated like elevator kind of area before. Like you do what you need to do. And you trust that the neuropsychologist has the training and the expertise to understand the data that they have and to make interpretations based on that training and expertise that yields valid results. And I see no reason that why, if we trust our neuropsychologists to do that in everyday practice settings, why we wouldn't also trust them to do that from a teleneuropsych perspective. So just to show you here, so again, I got angry. And I'm an advocacy guy, right? I do a lot of state federal advocacy. So I'm like, if you get angry, then do something about it, or quiet down. And I prefer people do something about it. So I've had some nice just internal funding here, looking at an RCT of teleneuropsych in patients with Parkinson's disease. So essentially, we'll be randomizing folks at baseline into either a traditional or teleneuropsych condition, bringing them back in 4 weeks, plus or minus 2 for repeat testing. And that time we'll also be randomizing, which is something that I haven't seen done before, because also what I want to interrogate here is the question of, does the first condition actually make a difference, right? My guess is probably not, but we don't know. A lot of the studies that were actually well done will take somebody who's had in-person testing at baseline and then randomize them at follow-up. But it is possible that the first condition does have an effect on, say, practice effects, over time. So we will establish that from a reliability standpoint. So we'll get reliability scores, but we'll also look really closely at the validity of these conditions in terms of whether it's normal MCI or folks with dementia. And the last plug here that I'll make and kind of open things up a little bit is what we're trying to do here through our research team, and what I think is really critically important is that we don't make the same mistake that we and most of healthcare have made since the beginning of time, right? So of the two things that kind of keep me up at night, right, is that one, back to what I said earlier, is that we've allowed this window of opportunity over the last 3 years where we've been able to do teleneuropsych clinically, and had this opportunity to study it, that we were sort of letting that slip by, and that because the science isn't as abundant as we would want it to be, that CMS will come and say, you can't do it any longer. And I think that would be a real shame. So that's concern one. And concern 1A is that maybe my preaching and soapboxing works a little bit, and we get some good studies out there, that we can have good advocacy work with AMA and CMS, and we can keep these codes alive, so that we can provide services to our communities, and that maybe in 15 or 20 years down the road, we'll start getting to the research that actually looks at cultural, variables, demographic differences, linguistic variables, and how that may or may not affect outcomes related to teleneuropsychology, right? We can't do that. We have no justification for doing that. We never did. But certainly with what we know now, and where healthcare in our society is at now, with the consciousness around the impact of cultural factors, our understanding of the changing demographics in our society, we have no excuse for not looking and examining the impact of these variables in our initial studies. We can't simply have this be like an add-on, decades down the road. So I think the time is right. I'll say too, this the ability to provide these services to more people is not going to be a fix all, right? It doesn't fix our entire healthcare system. It doesn't erase all of the inequities that are out there. And that's not, what I'm suggesting. And I do get worried that we are fearful of innovating or changing practice because it may not be perfect or solve all the problems. But if it can help solve some, that's good. And we're still going to have people that are out there who don't have. I mean, you see here, there's the broadband access is increasing in our society. More people have it. There's still some disparities from a racial ethnic standpoint, but those are actually pretty steadily decreasing, and also as the differences between rural residents and suburban and urban residents. But like, there's still issues, right? Not everybody's using this. So I think to recommend that we as a specialty shift solely to a teleneuropsychology practice in lieu of what we're doing now would be problematic. You'd be substituting, issues that perpetuate healthcare inequities for other issues, right? But I think we can be a little bit more nuanced and a little bit more intelligent than that, right? So how do we use a practice model and fold this in and integrate it into a broader practice model that allows us to provide these services to people that need it and want it in their communities, while also still making sure that we don't shut the doors to others who still need to come in for whatever reason that might be. So yeah, I think we can do both. And we're also at a time where, again, not only is broadband increasing, even though we need more advocacy around that, but with SciPac, we know that we can, practice across most jurisdictions now. So I think the opportunity is here. It's just more of a matter of kind of what we're going to do at this point to make sure that we don't lose it. And that's my spiel. I kind of went a little faster at the end, but so happy to chat about any of this. Pick my brain. I'll pick your brain maybe.
Hey, Scott, Tim Brearley here. Thanks for
Hey.
the talk. Can you hear me?
Yep.
Thanks for all you're doing for the field and really advocating for better research and for some of what this can be. I was wondering, do you have any thoughts on the role test publishers might be able to play, or maybe have been playing, either in road blocking or promoting teleneuropsych testing?
You got a lot of thoughts. Yeah. So this is part of a talk that like Monroe and Lana gave at like AACN. It's like 3 hours down to like 40 minutes or so. But like, that's like part of the what I would suggest is that needs to be the comprehensive advocacy, strategy, right? So I think what happens a lot is that the specialty, and even psychology, we do this sort of broadly, is that's kind of where we jump, and it's CMS isn't doing this, AMA sucks and publishers are awful, and I'm like, some of this all might be true, but it's so easy to do that instead of saying, what do I need to do, or what do we need to do as a specialty to put other people in a better position so that they can actually help us? And that's where we need to be, right? So my thought is actually that, again, we need to start with us. We need to produce better science and demonstrate that that the good science is actually going to have an impact on our practice models, instead of doing what we've done for the last 100 years and say that we refuse to change. We are going to test the same damn way we test with the same test, and we won't do anything different. And we'll still cry and complain about a lack of parity of respect around healthcare medicine, but we won't do anything to keep up with medicine, right? Or technology or innovation. I'm not even getting into like actual innovation, which I recognize is not even this, right? This is not even technological innovation. This is just, for me, a Band-Aid patchwork for us to be able to like provide services while we think about really more nuanced ways to reach people, in their homes, thinking about AI and other things. But the publishing companies aren't going to do anything different from a normative standpoint or, test development standpoint for no reason. So we don't demonstrate as a specialty that we're not invested in the science or the clinical practice of teleneuropsychology. Why would they invest in it? It makes no sense from a business standpoint, and I can't blame them for that. My hope would be that if we can show this, then over time, what will happen is more of an integrated test development model. I know some of these great. I do not think that we need a whole new set of norms for each individual test. I don't think we need to do that. I still think that misses the boat in terms of what our tests are doing and how we as the clinicians should be actually utilizing the test to make clinical decisions. But I do think that the teleneuropsychological assessment could be folded in to those standardization, approaches, as opposed to having these sort of two different lines of study, which I don't think is ever going to happen anyway. And I think that'll have good effects, not just on the clinical outcomes. We're not even talking about clinical research. And if we think about the massive disparities that we see in clinical research, and who is able to participate and henceforth benefit from clinical research because they're not, living next door to an academic medical center, well, then we might actually be able to reach folks and recruit better in those aims as well. So I think this has broad benefits both on the clinical and on the clinical research side.
Thanks.
We have a question from the chat. So I'm curious if you can comment more on your thoughts about the importance of validity without the essential need for scores to be reliable across modalities or within teleneuropsychology itself. I'm personally concerned that if scores are highly variable between or within testing modalities across 2 or more testing sessions, that we can't establish validity of a neuropsych profile if scores are also not reliable.
Yeah, so that's that wasn't what I was suggesting. What I was suggesting is that we've hit a hard stop at reliability, and we've overly scrutinized the reliability at the expense of looking at other things that are equally important, right? You can't have, this is 101, you can't have validity without reliability. Like we need, part of my study, I'm examining the reliability at each testing condition and across testing conditions. That's foundational. But it's not the end all, right? We still have to understand what degree of reliability, it's fair to say, and I think we should be interrogating this in our in clinic populations, right? This is why I don't think it's sort of a fair comparison. So what is the degree of reliability that I can have at any testing session or between sessions, whether it's in home or in clinic, and still get valid results, because we're not robots, right? So yes, we need to establish reliability, but we also need to look at validity, and we need to not do this as a one size fits all package, right? So this notion that either teleneuropsychology is good or not good, or we can do it or not do it, doesn't make any sense to me. So again, for my study, I'm giving tests that half the people I talked to thought I was an idiot for, because why the heck would you do these visual tests? Because we can't do visual tests on, via video conferencing. I'm like, well, have we studied it? I don't know. Let's figure out what tests are reliable and what tests are reliable in different populations in a way that yields valid results. Because I'm fine with getting, feedback from my study or results from my study that show, make up half the tests are good and half the tests aren't good. That's great. Now I know what I can do to provide clinical care to patients, what I need to do in clinic versus what I need to do, via telehealth. So reliability is important, but we have to look beyond it as well. Any other? Nobody? Usually this is well, I guess I'm in maybe a more like-minded group here. Usually people are attacking me from all angles for some of the things I suggest.
I think that
I just want to pause.
not a question. I just want to also thank you for all the leadership and all the work that you have been doing in the field, and especially all the work with the CPT and the CMS and everything. I think that it's great that you are there helping us to advance the field. I think that it's great everything that you presented, and I was kind of thinking of it resonated with me, all this need of developing the science, because I think that especially when you are actually talking to legislators and everything, that you actually have the evidence, you are in a different position to to negotiate and everything. And what we are seeing now in the clinic, in particular in my case, is like we have a lot of patients that were first tested using remote testing back in with the pandemic, but now they want to be tested in person because they want to come to the clinic. And it's the issue of like, how you compare their baseline with what we are actually having now. And I think that's, for me, like, I would love to have, like to actually have some metric to see like how these individuals are actually going through a neurodegenerative process, because we know that they have already a diagnosis or MCI, like what is the data to actually see the comparison when you actually have baseline with teleneuropsychology, but now you're actually doing the follow-up in person. As you were saying, like it's kind of like follow your clinical skills, but it would be great to have some data to actually back it up.
Yeah, I agree. So, and I think, I'm a fan of the copy paste, right? So, what I'm trying to do now is get this model up and running in either our CBH, which is our memory disorders, center here, and or general neurology, because I mean, you don't the study I have is sort of expands into some other things as well, but you can do this work in a very sort of clear focus. You don't need a ton of money to do it, and as you can answer a couple of really critical questions with a fairly small n, but make sizable contributions. So again, I'm always a fan of copy and, when it makes sense, copy and paste, right?
I know we're kind of over time, but I did have another question. Scott, I was wondering, like, so I'm working with Framingham Heart Study on like smartphone assessments. We've collected data on 1,500 people, and it's really interesting. We're now trying to understand, the construct validity and all of that measure. Yeah, I'm just wondering what your thoughts are on kind of, the future of neuropsychology incorporating these kind of smartphone remote assessments for clinical purposes.
Yeah, and that's what I was sort of alluding to before. I mean, that to me is my hope for the future. I think we've all done it, right? We've got a lot of neuropsych organizations, so we go to a lot of meetings and we hear or give the same talk every time. How many more talks do you need to hear about the future of neuropsychology? And it needs to be the wearables, and it needs to be innovation. And, can we keep tapping the same 4 people who have been preaching this and leading in this space for decades now, so that they can come and tell us that we need to do this, for us to shake our heads yes, and then to go home and do nothing different, right? That's where we need to be, right? We need to be thinking about, real innovation, whether it's wearables, certainly whether it's, other ways to, integrate sort of, AI and virtual, I can't even talk now. You know what I'm saying? There's just, we need to merge the cognitive neuroscience and what we're doing in the lab to the clinic. And we've known that for a long time. And we just don't. So my hope is that that's where we go. I'm not an optimistic person by nature, so I have fears that in 2, 5, 10 years we'll still be having the same conversation. But I hope not. And we need people that are, like you, that are in the space, that are pushing boundaries, and there are certainly others that are that are doing that. So I really applaud all of those efforts. And I think we need to, as a field, particularly those who are sort of senior in the field and might have more power or leverage, whether it's cross specialty guidelines or at the institutional level, where people in power get to make decisions about changes to practice models. And we need to make space for innovation and change, because we know that operating from a fear-based standpoint, which tends to be what psychologists do, is fear change, fear that computers and brief testing on tablets is going to take over. So instead of doing the work to be leaders in this space, we spend decades fighting it and then fall behind and complain about being behind.
Yeah.
So I hope the future has to be with you and what you're doing, or there really is no future. And I'm hopeful that that comes to fruition.
Yeah, no, I 100% agree. I think, the field is kind of being overtaken by people who are not neuropsychologists for developing tests and trying to interpret the data. And, I think you're 100% right. I think it's time that we take it in our hands and kind of become the leaders that we're supposed to become. Does anyone else have questions? I know we're running over time. Saranya had to drop off. She has a patient. So apologies.
We probably had to finish now, but thank you so much, Scott, for the time.
Yeah,
And
thank you.
it was really
Thank
great.
you for having me. I appreciate it.
Thank you.
Okay.
Thank you.
Bye.
Bye.
Thank you. Bye.